Good evening. My name is Tyler Granger. I am a member of the University Hospital's Marketing and Communications team. I'll be the moderator for tonight's event. On behalf of the entire University Hospitals family, thank you for joining us for our webinar on common hand and wrist issues, their causes, as well as non-surgical and surgical treatment options. Pain in the hand and wrist is more common than ever. Conditions such as carpal tunnel syndrome, trigger finger, tendinitis, and arthritis can affect your everyday activities and quality of life. A couple housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed in the presentation, please submit your questions through the Q&A feature, and our presenter will address questions at the end of their presentation. Also, this evening's webinar will be recorded and will be available for viewing on demand in the near future. It will be posted on our website, and as an attendee of today's session, you will receive an email with that link. It is now my pleasure to introduce our presenter. Dr. Jonathan Macklin is a fellowship-trained orthopedic surgeon specializing in hand and upper extremity surgery. Dr. Macklin received his orthopedic hand fellowship training at the University of Connecticut. He completed his residency, internship, and research fellowship training at Case Western Reserve University in Cleveland, Ohio. He earned his medical degree from the University of Pennsylvania School of Medicine and completed his undergraduate degree at the University of Pennsylvania, where he was recognized on the Dean's List and as a university scholar while competing on the men's varsity lightweight rowing team. Dr. Macklin is active in academics and has contributed to several articles and book chapters. He served as the editorial reviewer and associate editor of the Case Orthopedic Journal for the Department of Orthopedics at Case Western Reserve University. Dr. Macklin is a member of the American Academy of Orthopedic Surgeons, the American Society for Surgery of the Hand, and the American Association for Hand Surgery. Ladies and gentlemen, Dr. Macklin.
Thank you very much, Tyler. So again, I'm Dr. Macklin, based out of Geauga Hospital, but also currently see patients in Solon and in Mentor. And this evening, I'm going to be talking to you about some common hand and wrist issues. So thank you for taking time out of your schedule. And I'm going to try and touch on some of the more common issues. If there's something I missed or something that you have a question about, please certainly feel free to submit that through the Q&A that we'll do after I get through this first set of slides. So again, we're going to try and identify some common problems, also review how these problems are diagnosed, and also talk about some of the common treatment options that are available. So first, we're going to talk about carpal tunnel syndrome, probably one of the most common things that I see, and probably what a lot of people think of when they think of hand issues. So carpal tunnel syndrome is a disorder that's caused by pressure that's placed on the median nerve in the carpal tunnel. If you look to this picture on the left-hand side, you can see this is typically where we see some decreased sensation from the median nerve. That nerve supplies usually the thumb, index, and middle finger, and usually part of the ring finger for sensation. It also supplies a lot of the muscles that are here at the base of the thumb. And you can see on the picture of the right, like this cross-sectional picture, the median nerve sits inside of this sheath with 9 tendons, and those are the tendons that allow you to flex all of your fingers and your thumb. So typically, what we see with this is that symptoms are worse with activities that increase the pressure on the median nerve. Things that increase the pressure or decrease the relative blood pressure include elevated hand activities. So a lot of times we'll see driving will cause issues just because of that, raising the hands up for a prolonged period. We'll also certainly see that a lot with motorcycles and also overhead construction. Heavy vibrating equipment can also cause issues. Same thing we'll see a lot of times, especially now that it's nicer out, now that people are out on their bicycles, we'll also see those same types of issues coming from there. In addition, a lot of times we'll see issues when people are sleeping overnight. They'll wake up with a hand falling asleep. They'll have to wake up and kind of shake it out. The reason why that tends to happen overnight is when we sleep, a lot of us tend to sleep with our wrist flexed. We kind of curl up. And when the wrist is flexed like that, the pressure on the nerve is approximately 2 to 3 times more than when the wrist is out straight. So when we talk about evaluating for this, we certainly, talk to a patient about their history, kind of what types of symptoms they've been having. We also look for changes in sensation, also looking for weakness, again, in the muscles over here. Usually that weakness doesn't happen until much later in the course. So it's obvious, it's very important for us to identify, because that makes us more worried that carpal tunnel syndrome may be more advanced at that stage. The other thing that you'll sometimes hear about is electrodiagnostic testing. So essentially measuring how well that nerve is working by sending electric signals along it and measuring how long it takes for that nerve response to get from one place to another. We also talk about, how can we prevent this? So this is something that if you don't already have carpal tunnel syndrome, we do know that there are some disease processes that can contribute to diabetes. To carpal tunnel syndrome. And one of those is diabetes. So, want to control the blood sugars as much as possible. Keeping the hemoglobin A1C, one of the markers of diabetes, is as close to a normal range as possible. We also know that patients who have rheumatoid arthritis or other inflammatory conditions can develop tendinitis or tenosynovitis, which can cause swelling around the tendons, which can also put more pressure on the nerve. In addition, patients who have hypothyroidism, that's something we want to correct because we know that can also cause nerve issues. Now you'll hear a lot that typing, a lot of those things can aggravate the symptoms. What we don't have any real evidence of, though, is that any of those things actually cause carpal tunnel syndrome. So that's where put down here that there really is not any strong evidence that we can prevent carpal tunnel syndrome from work modification. But again, kind of avoiding those things, especially if you already have carpal tunnel syndrome. So, typically the way we start off trying to treat this is by decreasing the pressure in the carpal tunnel in order to improve the blood flow to the median nerve. The primary way of doing this is by splinting at night. Again, as I mentioned before, we tend to sleep with our wrist flexed. And if we can get it out straight, that takes a lot of pressure off of the nerve. And that can be something as simple as an over-the-counter brace, something that prevents you from flexing down. Now, typically I'll tell patients to just wear this at night, because a lot of times trying to wear a brace like this during the day can interfere with your normal activities. In addition, we also don't want to cause any more issues by creating a stiff wrist. Now, if the bracing isn't working, then usually that's when we start talking about surgery. What we know is that the pain that people have from carpal tunnel syndrome predictably gets better with surgery. What we don't have as good of an idea of is if the numbness will fully improve. A lot of that can depend on the severity of the compression. And what I typically tell patients, if there's a time of day where you're at 90% and a time of day where it's at 40%, usually we get pretty close to how you are at its best time of day. But if there is some degree of permanent damage to that nerve, it is possible to still have some residual symptoms after surgery. This is something that's in and out the same day. And it is something that we can do using local anesthetic only, meaning you could be totally awake during the surgery. And we don't typically put the hand into a splint or a brace or anything afterwards. Usually it's a light dressing with a few stitches, and you're allowed to start using the hand Typically don't want to be doing any big heavy lifting or anything along those lines, but you can start using the hand for light activities just while keeping those stitches clean and dry. You will also sometimes hear about using a steroid injection. A steroid injection can be helpful, but we know that typically does not provide long-term relief. So that's usually if somebody does fail the bracing, that's when we move on to the surgery. So moving on, the next topic is trigger finger. So this is something that I also see quite frequently. And a lot of times patients who have carpal tunnel syndrome will have trigger finger at the same time. And what this is, and here's a picture of, you have all the fingers have two tendons that run along the sheath, and it's kind of lives inside of a sheath or a tunnel. And what can happen is you can see on the blue tendon over here, that's not its real color, but you can see that you sometimes can get some relative swelling of that tendon. And then as this is moving back and forth, can actually get caught in the sheath. So that's why a lot of times with trigger fingers, patients will come in and they'll have pain down here towards the base of the finger, but where we'll actually see it catching and popping will be out at this joint over here. So again, patients will come in complaining of locking or clicking, or sometimes the finger may actually be fully caught in a flexed position. Similar to carpal tunnel syndrome, the symptoms from this can often be a lot worse first thing in the morning. The reason for that is, again, in addition to sleeping with a flexed wrist, a lot of times we sleep with our fingers closed, which can allow for that swelling to worsen, and then it gets caught. And a lot of times with this, patients have to use their other hand to actually fully open up the finger, and again, can have pain into the PIP joint. That's this knuckle over here. And again, that's because the tendon isn't moving freely, which can cause some irritation in that joint as well. So on physical exam, what we're looking for and what we're feeling for is we'll feel along here, and sometimes we can actually feel that tendon fully getting caught and kind of popping. Sometimes there'll be some crepitus or some crunchy sensation that we'll feel as the tendon's moving back and forth. And typically, again, pushing right around this level can cause pain. So our treatment options for this, sometimes if it's really early in the course and it's not really that bothersome, it's something that we find incidentally, we can watch with observation. Sometimes really early in the course, that's also when anti-inflammatories or sometimes splinting can be helpful. Essentially what splinting is keeping the finger straight overnight, or sometimes even just taping it here, so that instead of being able to make a fist overnight, maybe the finger can only come down a little bit, which can make the symptoms a lot better first thing in the morning. What tends to be very helpful, and usually our next line of treatment after that, is a corticosteroid injection. We know that this can get rid of it in patients who do not have diabetes. A corticosteroid injection can almost be curative of this about 60 to 70% of the time. In patients who are diabetic, while a lot of times a steroid injection can be helpful, sometimes it has a higher frequency of coming back at a later time. That doesn't mean it's not something we won't try, but that's just something to be aware of. Ultimately, if none of those things work, or if a patient has a contraindication to having an injection, that's when we talk about surgery to take the pressure off of that tendon. So as I was saying before, the steroid injection has a pretty good success range for the first injection. Repeat injections, we do know, can still be helpful, but we usually know that the more injections you do, the less likely that injection is to work. The other important thing with anything that we're talking about a steroid injection is that patients who do have diabetes, their blood sugars can raise for up to 5 days or so after any injection that we do. So the surgery, Again, as I was saying, it just involves a small incision right over where that tendon is getting caught. This is another surgery. It's in and out the same day, and also another one that we can do using local anesthetic only. Some patients do elect to have some light sedation, but again, it's a nice option to have to avoid any complications from any anesthesia or whatnot, if this is something you want to be able to do and then drive yourself home afterwards. So one of the other really common things that I see, and something that also starting to see more of now that people are out golfing and everything else here in Cleveland, is basal joint arthritis. So what this is, it's arthritis in the joint towards the base of the thumb. It's something that we see more commonly in females, but certainly still see it with a pretty high frequency in males as well. Tends to increase in frequency with age. And over the age of 55, we see this diagnosis in approximately 30% of women. Typically, patients have worse symptoms with more advanced arthritis. Now, that being said, x-rays don't always match up with the patient's symptoms. Sometimes we'll see a patient with really bad x-rays, really bad arthritis, and maybe it doesn't bother them as much as someone who has more mild changes on their x-rays. But ultimately, we're trying to treat the patient, not the x-rays. So the symptoms that people will get with this is pain, especially from things like gripping and twisting. Also stiffness in the thumb, and oftentimes patients will have weakness secondary to that pain. And again, pinching and grasping, using a key, all those things can be more and more difficult. So this is a series of x-rays. As I was saying before, symptoms don't always match up exactly to what it looks like on the x-ray. But this kind of gives you an idea. There's a progression here from left to right, where on the left, there's actually a little inflammation. So you can see there's actually a little increase in the space here at the base of the thumb. And as we move further and further to the right, there's more joint space narrowing. There are also little osteophytes. And by that, I mean these little bone spurs here. So on exam, patients with this will oftentimes have tenderness here. Sometimes also we'll kind of push, on the back of the thumb here as well. We try and elicit that by kind of doing what's called a grind test, kind of pushing in there. And also sometimes in more mild disease, we'll actually feel a little bit of joint laxity. So how do we treat this? So our first line of defense is activity modification. That's where our hand therapists can be extremely helpful for us. You know, a hand therapist and activity modifications aren't going to get rid of the arthritis, but a lot of times there are other ways to do things that allow you to do the activities you want to do, that you need to do, without aggravating the arthritis. And a lot of times when you're able to do that, that might then allow you to do another activity that would normally bug you, but maybe because you haven't aggravated the arthritis as much, you're able to do that. Also, anti-inflammatories. Now, this is not something, with anything that I treat, I don't want patients to be on oral anti-inflammatories long-term. Certainly worry about stomach issues, heart issues, and that's not something that we want to be causing. We don't want to cause a heart issue when we're trying to deal with arthritis in the thumb. We'll also find that splinting can be extremely helpful. In this picture over here to the right, that's one example of a splint. This is something that I tell people that there are literally hundreds of types of splints on the market for this, which tells you there's not necessarily one that works better than another. That being said, some of them are certainly bulkier. Some of them are sleeker, like the one you see over in this picture. And really it's about finding one that lets you still, potentially use it, but also still do the activities that you want to be doing. We also find that steroid injections can be very helpful for this. Now, that's, again, not going to get rid of the arthritis, but it can be helpful if there's a flare of the symptoms to help hopefully kind of bring that back down. Ultimately, again, if none of those things are working, that's when we start talking about surgery. So if you ask 10 different hand surgeons how they do that surgery, you'll probably get at least 11 different answers. Ultimately, what the goal of that surgery is to remove the arthritis and create a new stable joint so that patients are still able to use their hand, use their thumb. And it's fairly reliable for pain relief. The one thing that we do know is that patients don't ever really get back their normal grip strength. And when I say that, I mean the grip strength they had before the arthritis. But that being said, by the time we're doing this type of surgery for patients, there often has been a loss of grip strength because of the pain and because of some of the deformity that can be associated with the arthritis. So moving on to a form of tendonitis, which is one of the more common types of tendonitis that I see, especially with new activities. I've seen people who have been cleaning out their garages and doing a lot of lifting. With de Quervain's tendonitis, it's also something that we see a lot of times in new parents, new grandparents, again, because they're doing a lot of lifting motions. So what de Quervain's is, it's a tendonitis of the first dorsal extensor compartment. You can see in the picture off to the right, that's kind of right where that arrow is pointing. So there are two tendons that come off the base of the thumb here. And essentially, what those tendons are really important for doing is abducting the thumb, so bringing the thumb out, and also bringing the wrist ulnarly, so kind of and so I'm sorry, I misspoke. So just abducting the thumb, and also gets put on stress when you ulnar deviate. Again, we see this a lot of times in people who are doing new activities that involve a lot of lifting, and it's aggravated by that thumb movement. So with the exam, again, usually we elicit this. There's usually a lot of tenderness directly over that area. And also when we bring the wrist ulnarly, so again, kind of towards the pinky, it stretches those tendons out, and that can also cause a lot of those symptoms. So treatments for this, a lot of times we'll start with bracing. One difficulty that we can have with bracing is that because that area can be tender to palpation, tender to touch, a lot of the braces tend to kind of push on that area. And because of that, bracing is not always really well tolerated. Again, can try a short course of anti-inflammatories. And this is one of the things that has a very high cure rate with a steroid injection. So even though I see a lot of this in my clinic, it is a less common thing to operate on relative to how commonly I see it, because again, the conservative treatments work really well. So, doing an injection, doing up to 2 injections cures this about 90% of the time. And this is also something that's typically safe to do while someone's breastfeeding. Again, we see it a lot of times in new mothers. The things that we look out for that is sometimes it can slightly discolor the skin. If it does discolor the skin, usually it lightens it up in color. That's something that usually returns to normal within 3 to 6 months. It can also cause some degree of fat atrophy. So if there's a little fat over there, it can actually kind of become slightly indented. Not something that we see too often here, just because there tends to not be a lot of fat in that area, but again, things to be aware of if you're considering that treatment. And again, if none of those things work, that's when we start talking about surgery. Again, this is something that is in and out the same day. So another common thing that I see is something called Dupuytren's disease. And this is typically something that is not painful. What it is a contracture that can form in the hand and can actually cause the fingers over time to gradually contract in. This most commonly we see as a genetic. So a lot of times we'll ask patients and it turns out their parent or grandparent had it. We see a lot of times in patients from Northern European descent. They call it the Vikings disease. We'll also see this secondary to other systemic diseases, in particular diabetes. This is something that we do see more commonly in men than women. And also when we do see it in men, it tends to present earlier in life. As far as the aggressiveness of this, sometimes people will come in for something totally unrelated and we'll just make note that there is some Dupuytren's disease there. It's not something that they necessarily noticed or was bothering them, but can just be some thickening in the palm. So that would be a really mild form of the disease, and that might be something that never warrants any treatment. However, we do know that the earlier that this shows up in a patient, the more aggressive it tends to be. So as far as treatments for this, currently none of the treatments are curative. And what I mean by that is that because there is some genetic bias towards developing this, nothing that we do is going to go in and change a patient's DNA. We're trying to treat what actually has occurred with the Dupuytren's disease. So actually go in and remove that tissue that's causing that contracture. So there are a few different ways that we talk about treating these. Initially, all we really had to treat this was surgery. So going in and surgically removing that extra tissue and then mobilizing a patient afterwards with therapy. Currently, we have two other different ways of treating it. One of those is a needle aponeurotomy, which essentially involves going in with a needle after numbing up the area and actually cutting the cord so that the cord is still there, but it's broken up so you can move. Also, collagenase injections, which is something that's been available really over the last 10 to 15 years. And what that involves is coming into the office, having an injection of this collagenase, which dissolves the cord. Don't do that in the office. Come back a day or two later where the finger is manipulated and straightened out. So that wraps up the bulk of the presentation that I had prepared. I'm certainly happy to answer any questions if there's anything that I didn't address that you want me to address.
Thank you, Dr. Mackin. We will, if you have a question, please submit it through the Q&A function. We have a couple of pre-submitted questions that we'll start with while those who have questions submit them. So the first question, I do a lot of crocheting, which requires me to hold my left hand in a semi-fist position with the index finger extended to control the yarn. I am experiencing pain in my index finger that travels up my wrist. I have 2 trigger fingers on that hand as well. What could be done to control this pain?
It's hard to know exactly what it is without examining. Certainly that type of pain, it could be related to the trigger fingers, in which case, would want to address those. And again, as we talked about, that can be a steroid injection, or if you've already had that, could involve surgery. As far as the index finger goes, it's also possible there might be some degree of arthritis. That's where it would be really helpful to potentially get x-rays and kind of examine and make sure that we're not missing something else.
Thank you. The next question, my hands and wrists have sharp shooting pains. What could this be caused by?
I'm sorry, the hands and wrists have sharp shooting pains?
Yes.
Okay. So I think a lot of the stuff that we covered today could encompass that. So sharp shooting pains, sometimes that can be from arthritis, and just kind of kind of aggravating that at times. Sometimes we'll also see sharp shooting pains from tendonitis. Things like trigger finger can cause that sharp pain. And because it's involved in allowing the tendons to move, sometimes we can see that jumping up. And things along those lines. So I think that a lot of the things that we covered today could potentially be causing that, and that's again where coming in for a formal exam and figuring out if there is something that we can do long term would be helpful.
Are there exercises one can do to prevent and alleviate hand and wrist pain?
So for exercises to do, I think one of the most important things is quite honestly just staying active. What we don't want to do with hand and wrist pain is we don't want to put you into a brace or put you into something where you don't use it and we create a lot of stiffness. The hands in particular are very sensitive to being held in one location, and that stiffness can actually cause additional problems. So I think, if I wouldn't tell you that there's a specific exercise routine that I would give you, but certainly would advocate for remaining active and continuing to move. And, depending on the diagnosis, that's where a lot of times we'll get a hand therapist involved for possible, potential strengthening of specific areas to address a specific diagnosis.
Similarly, can stretching and/or massage help with these issues? What's a good source of training for self-hand massage?
So I think that hand massage can certainly help. As far as training for that, I do know that our hand therapist a lot of times will work on kind of specific desensitizations. I think that there's probably also some other alternative medicine sources of that, but the ones that I work with most frequently are with my hand therapists.
My right hand gets numb and hurts only when my right shoulder hurts deep inside. But why does the wrist sometimes lock up and hurt severely?
So, when we do see hand numbness associated with higher level numbness or aches and pains, that does sometimes concern us for possibly something coming from the spine. And that's where having a good examination can come in play and be very helpful. And that's also where sometimes we get my spine surgery colleagues involved. Now, that being said, a lot of times if they're concurrent issues, meaning you have something in the neck and something coming from the wrist or the extremity, a lot of times if the severity of the spine issue doesn't seem too great, we will address the wrist or the elbow issue, because those tend to be things that are easier to recover from. Oftentimes that numbness and tingling though is separate from some of the aches and pains, which again could be arthritis or tendonitis or a whole host of other issues.
All right. My husband has weakened wrists and ankles from the drug Cipro. He tripped 3 weeks ago and landed on his palms, still suffering some pain. What should they do?
So whenever there's a trauma, it's our default. We really like to get x-rays. The reason for that being is that sometimes there can be an occult, or there can be a fracture or an occult fracture, something that doesn't show up on the initial x-rays. And that can be something that we don't want to miss that and discover it 6 weeks later, 8 weeks later. A lot of times those injuries can be much better addressed acutely, meaning closer to the time they happen.
All right. Can carpal tunnel syndrome arise as a result of a distal radius fracture?
So yes, we do see carpal tunnel syndrome occurring after distal radius fractures. So that's something that a lot of times if a patient comes in and has a wrist fracture, always asking if there is any numbness and tingling. because that is something that if it is present at the time of injury can potentially change how we treat that wrist fracture. It's also something though that can happen down the road, and sometimes that can be from some of the swelling, some of those other things that cause additional pressure on the nerve. In addition, if the wrist heals in a slightly different position than it had been in, that can also cause some degree of nerve compression if that nerve has to, instead of going a straight course, is traveling and then kind of curving a little bit.
All right. If you have some tingling and numbness halfway up your arm from your wrist, but not as far as your elbow, could that be associated with carpal tunnel?
So yes, it can be. A lot of times, even though it's not necessarily classic, a lot of times we will see patients who do have symptoms in their hand that radiate up their forearm. And sometimes we will see those improve afterwards. Again, that's where we try and do as thorough an exam as possible beforehand, because we want to make sure that we're not missing something else.
Can there be something else going on if you have some of the carpal tunnel symptoms, like up higher in the arm? Also, can you help the symptoms with some stretching and massage? I saw a physical therapist give some tips on that.
So as I was saying, yes, certainly it can be from something else. And that's where, we want to do a really good exam to make sure that we have a good handle on where that numbness, tingling, those symptoms are coming from. As far as stretches go, for carpal tunnel syndrome, the data shows us that if you have extremely mild symptoms, that sometimes therapy can be somewhat helpful. But that is not something that we're regularly doing as part of our treatment, because we know that for more advanced symptoms, that it typically does not have a huge effect. And really the bracing is more effective.
I play the clarinet and I have basal joint OA. Will surgery affect my ability to play?
So luckily I feel qualified to answer that because I played clarinet for a while and I haven't recently. I guess the question is if it's the right side or the left side, if you're using that to support it. I think certainly could potentially alter, just how you're holding the clarinet. I would be hopeful that over time, you'd still be able to get back to doing that. As far as surgical treatment for basilar joint arthritis, that's not a surgery that we do and you feel great the next day. There certainly is a recovery course associated with that. So typically a patient is immobilized for about 4 to 6 weeks after surgery. Usually for between weeks 2 and 6, that's a removable brace, but still wearing that most of the time. And usually around 4 weeks is when we start doing some gentle range of motion. So, as far as getting back to heavier activities, getting back to, if that's the right thumb and you're supporting the clarinet with it, that could potentially be 2 to 3 months that you would not be able to support and play.
Right. Is physical therapy recommended as a way to delay or avoid surgery, or is PT mostly used after surgery?
So I think that therapy can be really helpful beforehand. It's also extremely crucial for a lot of what I do afterwards. Now, typically, I'm using an occupational therapist that's also a certified hand therapist. We're really lucky in the UH system that we have a lot of occupational therapists that have done a lot of additional training and are certified in hand therapy. Now, there are occasionally physical therapists that are certified in hand therapy. I don't believe we have any in the state of Ohio. But a lot of times it can be helpful beforehand, especially for things like CMC arthritis, or kind of teaching how to different ways of doing things and hopefully, potentially even avoiding surgery. The other thing that therapy can be really helpful is making sure that we're maintaining strength, maintaining the mobility, so that if it does come down to surgery, that you're kind of starting ahead of the curve, and we're not struggling to catch up on strengthening and mobility because it's been a while since you've been able to move something.
All right, I broke my wrist 7 years ago and it was repaired with a plate and screws. Could this cause the arthritis or tendonitis and cause pain in the hand and going into the lower arms as well over time?
So the vast majority of plating, the hardware we use for wrist fractures now is fairly low profile, and usually we're not finding the need to remove it. Now that being said, certainly if there was an articular component of that fracture, meaning if the break went into the joint, that could potentially lead to arthritis. We call it post-traumatic arthritis down the road. There also can be some degree of tendonitis, and some of that depends on how prominent the plate is, meaning how much that plate is sticking up, either on the volar surface, or sometimes we also worry that the screws might also irritate tendons on the other side, on the back side of the wrist. And if that is the case, then yes, it certainly could cause it, and that would be something it would be worth getting checked up, and getting new x-rays and making sure everything still looks good with the fixation.
What is the recovery time for carpal tunnel surgery?
So with carpal tunnel surgery, what I tell patients is that you're allowed to use the hand right away. That doesn't mean you're going to want to go outside and lift 500 pounds right away, but can do light activities. The stitches are in for about 2 weeks. We know that it's an incision in an area that you use a lot, so it's not uncommon to have some degree of soreness there for a month or two afterwards. I equate it, you get a really bad paper cut and it can be sore when you hit it 6 weeks later. Very similar to that. We know that grip strength can take about a couple months to fully return to what it was before surgery. And the reason for that is because when we release that ligament, all the muscles by the base of the thumb and at the base of the small finger all insert on that ligament. So it just takes a little bit of time for those muscles to kind of readjust to their new positioning.
All right, do people sometimes have more than one of these issues?
So very frequently. For instance, we know that 50% of people who have basilar joint arthritis in the base of the thumb, have carpal tunnel syndrome. Also, we know that a lot of patients who have carpal tunnel syndrome will have trigger fingers at the same time. And we also know, after any surgery, especially we'll see it after carpal tunnel surgery, whether it's a month later or a year later, patients can go on to develop trigger finger. So, it's not uncommon for a patient to come in and see me about one or two things, and, we leave having figured out 4 or 5 different diagnoses. It's very common. There's a lot of things in the hand that are very close together. And so it's very common, though, to have the same multiple issues in the same hand.
Right. I cannot do push-ups or some yoga poses because my wrist won't bend enough to that angle. How do you remedy this situation?
So, excuse me. So I tell patients that push-ups are one of my least favorite exercises, even in a totally healthy, totally normal wrist. The reason for that is that, when you think about the most powerful position for your wrist, you go to make a fist, you go to do something, and that wrist is only tilted backwards about 20 or 30 degrees. And if you look at the bones in the wrist, that's really the ultimate, that's the best spot for those bones to be as far as the stability and accepting a load into the wrist. What extending the wrist does is it kind of puts the cartilage, the padding, kind of right on edge and really loads a part of the wrist that wasn't necessarily designed from an anatomic standpoint to have a lot of force going through it. So, typically with that, I recommend that patients modify those exercises. So, for things like push-ups, I'm not sure if you all remember in the 90s, there used to be the infomercial for the perfect push-up machine. Now you don't have to get a perfect push-up thing to push up, but a lot of times using something like a 5-pound weight so that, when you do a push-up, you're doing it straight down as opposed to trying to do it on a hyperextended wrist. And a lot of times just those simple modifications allow you to continue doing the exercise you want, that's slightly modified.
All right. Are there any elbow conditions that manifest themselves as hand or finger numbness, and what are the treatments?
So yes, anywhere the nerve runs by, there's always potential for numbness and nerve-related issues to happen further downstream. So at the elbow, the most common one that we think about is what we call ulnar neuropathy. That's the funny bone nerve. It kind of sits on the inside of your elbow, and it's never funny when you actually hit it. That typically causes numbness and tingling into your small and ring fingers, and can also cause weakness into the hand as well, because it supplies a lot of the muscles in the hand. In addition, you can also have compression of the median nerve, which is the same nerve that we see at the carpal tunnel, but we'll see other weakness and whatnot if it's compressed higher up. Really, for all of these types of things, sometimes therapy can be helpful, and sometimes modifications. So with cubital tunnel syndrome, a lot of times we'll have patients try and avoid prolonged activities with their elbow flex because that puts a lot of pressure on the nerve. And sometimes we'll have you sleep with a wrap around the elbow just to try and prevent that flexion. And there are also surgeries that we can do to take the pressure off the nerve if the conservative treatments are not working.
Is there anything special for gout in the wrist?
So, I can't think of anything in particular, that we do to treat it differently. Ultimately, that's something that, patients who do have frequent gout attacks, trying to work with primary care doctors or rheumatologists, what have you, to see if we can better control the gout. And if it is something that continues to be an issue, sometimes consider doing steroid injections, and that can also be helpful for an acute flare. Now, we do know that gout in the wrist can also be associated with a lot of arthritic changes in the wrist as well. And if those come about, there are also ways to manage that.
All right, next question. Can you feel nerve numbness up into your forearm and shoulder?
So yes, and a lot of that can depend on where the numbness is coming from, whether it's coming from the neck or, as I was saying before, sometimes that numbness in the hand, patients will have it radiating into the forearm.
All right, what info can you give about knuckle replacements?
So knuckle replacements, well, they're we're talking sometimes here, sometimes down here. So that's something that can be helpful for end-stage arthritis. They're, most commonly, I think what you'll see most commonly is what's called silastic implants. Essentially, they're medical grade rubber type component or plastic that goes in and replaces the joint. So essentially gets rid of the part where there's arthritis. And, we do know that those typically will last about 10 years or so. Now, a lot of that depends on the activity level of the patient. We know that they can be extremely helpful for kind of continuing some degree of mobility with relieving the pain from arthritis. And um, there are also other types of implants, although I would tell you that's the silastic ones are the ones that I personally have the most experience with.
Right. What's the most expeditious treatment for a wrist sprain or strain?
So if you can figure out something that makes a wrist sprain or strain go away really quickly, let me know. I'm happy to invest in it. So what we often find is that wrist sprains and wrist strains, and we'll see it a lot of times even with wrist fractures, where the radius will break, but patients will continue having soreness over on the ulnar side of the wrist where they essentially have a bad sprain, and that sprain may hang around for 3 to 6 months. Um, the biggest thing with a sprain or strain is that a lot of times we'll try and immobilize it, ice it initially, but then again, what we don't want to do is make the wrist really stiff. And that's where, again, the hand therapists I work with are very helpful in gradually mobilizing, but also kind of trying to strengthen and help stabilize the wrist as we get people moving.
With mild or moderate carpal tunnel, will surgical intervention for carpal tunnel decrease occurrence of trigger finger?
So I can't tell you that I'm aware of anything that would make it decrease the incidence of trigger finger. That does bring up an important point though, because a lot of times we'll assign these names like mild, moderate, severe. And really, I would go back and emphasize that the goal of treating carpal tunnel syndrome is to prevent things from getting worse. Um, what we don't want to have happen, I'd much rather, I treat all patients, but if I had to choose between a patient who had really severe symptoms that were constantly there versus someone who had symptoms coming and going, the patient who has the symptoms coming and going is typically going to have a better outcome because we know that at some point during the day, the nerve is relatively healthy. When those symptoms progress to a point where they're really severe and having constant symptoms, that patient is much more likely to have some degree of residual symptoms. So, it's something that if it's bothering you and it's continuing to progress, it's better to treat it when it's more on the mild, moderate side of things than it is on the really severe side of things.
Right. My pain is on the outer pinky side of my wrist, below the hand joint, right in the wrist area. None of the conditions you reviewed seem to cover pain in that area. Any ideas?
So, that's kind of what I was referring to with the wrist sprains. So there are a lot of soft tissues in this area. And, when we talk about, there's a very long list of differential diagnoses that could include pain in that area, from tendon subluxation to ligament injuries. And so there really are a lot of things in that area. And that's where, again, having a physical exam and having a better history of exactly how long things have been going on, when it started, what types of things aggravate it, can be really helpful in determining a diagnosis and also a treatment plan.
Right. The joint in my middle finger is swollen and extremely painful. What could this be?
So, anytime we see any kind of swelling, our number one concern is it an infection? If that's something that's been like that a long time, infection is probably less likely, but still it's always there in the back of our head because that's not something we want to miss. A lot of times it can be arthritis. And also a lot of times we'll see associated with trigger finger swelling into the middle joint. And a lot of times, a lot of times that's just related to the fact that that joint is not moving as well. So that's where, x-rays can certainly be helpful, and also kind of examining it a little bit more closely.
All right. Can carpal tunnel issues return years after surgery?
So yes, they can. Ultimately, what we know with carpal tunnel syndrome is that it's at the end of the day, it's an issue where that's too confined of a space for the nerve and the tendons. And what we know is that typically, we'll see it in patients who have had the surgery done when they were younger. There is a risk of recurrence. The literature says it's about 5% of cases will have symptoms come back. And the reason why that can happen is we are not, we're not leaving the nerve open to the air. We're still closing the wound. So there's still a closed space that nerve is living in. So it is possible for those symptoms to come back. And, that's when, depending on the severity and, making sure that it is in fact from that, sometimes we'll talk about surgery.
All right, I have discomfort in my left inside the base of the left thumb and right thumb. It is especially noticeable when I play golf. Would a cortisone shot be helpful?
So, I'm guessing that could potentially be from thumb arthritis. Could also potentially be from some slight tendonitis along the flexor tendon. And that is where, certainly a steroid injection could be helpful. That's something that a lot of times when you're playing golf, you can't necessarily wear a brace, even though some of the brace companies would have you thinking otherwise by having pictures of people golfing and playing tennis on their websites. But that is something where a steroid injection can be helpful.
All right, next question is, it's likely I have early stages of basal osteoarthritis or possibly the D tendon issue. Will wearing a thumb brace that keeps the thumb neutral help the progression?
So, I can't tell you that it would necessarily help prevent progression of, the actual arthritis, but a lot of times it can help with the symptoms. And really with that, we're really trying to manage the symptoms there.
All right, I have a cyst or small lump on the inside of my wrist. It's painful and has caused wrist weakness. What could this be?
So, there are a lot of things that can cause lumps and bumps. That is something, most of them are benign. We do always worry in the back of our heads that it's something that is not benign and could potentially be more dangerous. That being said, the most common thing that we think of is a ganglion cyst, which is some fluid that has come out of one of the joint spaces. And that's something that if it is a ganglion cyst, it's not something you necessarily need surgery for, but if it's bothersome, we do sometimes consider doing an excisional biopsy where we go in and remove it and send it to the lab to make sure it's nothing dangerous, and would hope that would provide some relief.
All right, we have time for a couple more questions. With basal joint arthritis, does it present as a bump and redness between thumb and wrist on the top of the hand?
So certainly can present as a bit of a bump. What can happen is that as you develop arthritis in this area, sometimes we refer to it as a shoulder deformity, where the edge of the thumb kind of seems to sublux out. So that bone that was sitting like this kind of kicks out a little bit. Usually don't see redness unless that's an area then, because of its prominence, is getting rubbed a little bit. So that, I think that's how I can best answer that.
All right, with carpal tunnel, is early intervention better or okay to wait to see if it is a temporary issue that goes away?
So, when we look at the natural history of carpal tunnel syndrome, typically we'll see it gradually progress, kind of progress in a stepwise fashion. We fairly rarely do we see it fully resolve. Most commonly, when we see it resolve, it's carpal tunnel syndrome that was associated with a temporary condition. So I don't want to call pregnancy a condition, but it's something that's temporary. So some patients will get carpal tunnel symptoms while they're pregnant, but then as soon as they give birth, the fluid balances shift and it goes away. So oftentimes we will see that it will progress in the future.
All right, that's about all the time we have for questions. Thank you, Dr. Mackin, for your time and sharing this information and answering these great questions we received. A couple of reminders for the audience. We will be emailing you a link to view this session on our website soon. If you have any further questions or would like to make an appointment with Dr. Mackin, call 440-732-4529 or visit uhhospitals.org/ortho to find another great provider by you. This concludes tonight's session. Thank you for attending, and we hope you join us for future webinars, and have a great evening.